Hi everyone. To those who may be joining later or who are going to be watching this on YouTube, thanks so much for joining us for this short presentation. It's not going to be too long. We're just talking about open mouth X-rays of the C-spine. So open mouth X-rays of the C-spine are one of those X-rays that you would do quite commonly in a trauma setting. And I found a lot of people do order them or don't order them sometimes, and when it's needed, and even when ordering them, sometimes I'm not sure, exactly what they're supposed to be looking for. So in this short tutorial, I hope to just break it down for you so that you guys know more or less what we are looking for and why we are looking at an open mouth X-ray. Now, if you're interested on the channel, there's a whole lot of C-spine videos that I've done, about 4 of them. And if you go to the Radiology Essentials playlist, you'll see that there's about 4 or 5. So this one here was just specifically based on a case that I had been asked about, and I could just see that the junior doctor was just struggling a little bit. So I decided to just make one just so that it concentrates on this little thing, or this little area that we all need to know about. So first of all, just the anatomy of what you're looking. So this is generally what you'll see when you get an open mouth X-ray, and what we have is C1 at the top, and we have C2 at the bottom with the odontoid peg over there. This is, of course, the joint space. This is the inferior facet of C1 and the superior facet of C2, which we don't really pay too much attention to. Of course, you can see the mandible and the teeth, and you can see a bit of the alveolar ridge. So there is a little bit to see around those areas. The most important things to note, however, on a normal open mouth view and on a normal C-spine, what you're looking for is basically, let me try and draw it out here just so that we have it nicely put. All right. Let's just close it. Oops. Let's try and get this here. So what we're looking for is that this C1, C2, my apologies if there's any noise in the background, that would just be my kids. So we've got this nice relationship between C1 and C2, and you can see they're quite nicely aligned. The other thing that we're looking for is the top of the body of C2, and we're looking here specifically at the odontoid peg that you can see running over there. So when you're just having a glance in an emergency department, where we often don't have time to do major, long reviews of X-rays, these are essentially the 2 most important things that you are looking for. So you can have fractures, you can have dislocations. There's quite a bit that you can have. The other thing, of course, that lets you know that clinically there's something wrong with C1 and C2 is, like for any C-spine injury, there's difficulty in rotation from side to side. There's direct tenderness on the C-spine. But I think the most important thing is that your patient, especially if there's quite a severe fracture, may have episodes of mild bradycardia. But although we don't see that too often in an emergency setting, it's one of those things that you may find. But the most important thing is pain on that C-spine and an inability to rotate past 45 degrees in both directions or one direction should point you in the fact that you need to do a C-spine X-ray on the patient. So now that we know what we're looking for, it actually becomes quite easy to actually look for abnormalities. So let's look at some of the abnormalities that may occur. So, sorry, let me just get this here. All right. So this is just, let me just hide this here. So this is just to show you the atlas and the axis, or C1 and C2. So C1 is equivalent of a ring. All right. So you've got your odontoid process there, your superior facets, that's where they sit. You've got your transverse ligaments sitting at the back. You've got the grooves for the vertebral artery that is sitting on either side, the anterior arch. But essentially, you've just got to think of it as a ring or a donut. And your C2 is also very similar. It's also a little ring that's just sitting over there. The difference being, of course, the odontoid peg or the odontoid process that's sitting over there. And you've just got a bit of a bifid spinous process. So if you're not familiar with the anatomy, it's good to get familiar with the anatomy just so that you know what's going on. But essentially, if you look at it, the odontoid peg now fits through this area of the of the C1 of the atlas. So you've got the transverse ligament at the back. You've got cruciate ligaments that run. There's quite a few ligaments that actually run over there. But for the purposes of this, you can just imagine this slotting over that so that it forms one functional unit that sits over there. So the first thing that we are going to look at is that we're going to look at a Jefferson fracture or a burst fracture. Now, a Jefferson fracture is quite easy to pick up now that we know what we're looking for, because essentially we're only looking for two things when we look at this. So let's first look at this X-ray that we've got on this side. So here we have our C1 and our C2, and we can see there's quite good alignment between the two. So that's quite good. Now let's come to this one. And what we can see is that we've got C1 over there, and we can see that there's a lateral movement of C1. So you've got that, and you've got, again, something happening over there. So this is a burst fracture. Now, to explain what a burst fracture is, and this is a very easy fracture to pick up. Let's go back to, I think I've got a picture of it, but let's just move back to this. So as with any ring, when a ring breaks, if you've got a donut, your wedding ring, any sort of ring, it's very difficult for it to only fracture in one place. Generally, when rings break, they break in 1, 2, or sometimes even 3 places. So what happens is that, let's say, for instance, you've got a fracture of C1 here. Let's put it here. All right, you've got a fracture there. And what will happen is the fracture line will tend to occur in 2 places. So what will now happen is that once you've got your fracture lines happening over there, this section will now start to move in that direction. All right. And this section will start to move in that direction. And it's the exact same thing for C2. So if C2 has a fracture, for example, let's say running through there, all right, it will likely run through there as well, or it may even fracture in another area, for example. But I'm just trying to make it easy for people to understand. So once you have that fracture, then these pieces start to move away. All right. So they start to move away from the central area. And that's when you get this picture like what you're seeing in our fracture over here. So let's just go back to that. So again, let's just do it one more time, just so that everybody can get a good idea of what a burst fracture looks like. Now, burst fracture is an unstable fracture. By definition, your patient needs to remain in a hard collar. Your patient needs to be seen by spinal surgery as quickly as possible. Your patient is at very high risk of having a high level paralysis should the spinal cord be affected. So these are some of the most important fractures that you need to know. So here we can see again, basically what's happened is that we've had a fracture somewhere along C1. We don't know exactly where, we can't see it here. And what's happened is that C1 started to move out in that direction. So that's why we're seeing that step. So C1 is now moved away and is now causing a burst fracture. Now, conversely, this can happen with C2. So you can have this image flip. So you can have a step that goes that way instead of what we are seeing here, a step that goes in that direction. Okay. So let's have a look at it and see. Sorry, just trying to get this again. All right. So here we can see what it looks like on a CT scan. So here again, we see this anterior arch, the posterior arch, where the vertebral artery should go. And there we see the odontoid process or the odontoid peg. And we can see the fracture and the fracture. And we can see that it has started to move away from they've started to move away from the central axis or the central area. So that's how we know that we've got a fracture, right? And it is a dangerous fracture. Once your patient gets these high fractures, these are the types of patients who then struggle to breathe, who struggle to maintain heart rates, who need to be on pacemakers and lifelong, breathing apparatus and things like that. So these are the types of things that you need to worry about. Now let's look at another one. Let's look at an odontoid peg fracture. Now remember, it's very easy. We've already had a look at the alignment. So let's look at a normal one first. So here we can see the alignment between C1 and C2. And then we have a look at the odontoid process or the odontoid peg. So here we can see it quite easily. All right, so that's quite easy. Now let's just do it in another color. Let's pick orange. So let's look at a fracture and see what we see now. So here again, we see nice alignment between C1 and C2. You can see it running over there. But as soon as we come here and we go to our odontoid peg, here we can already see the problem. All right. So let's just get this in another color so that we can see it again quite easily. Let me pick a nice color here that will just stand up. So here we can see a fracture at the base of the odontoid peg, and it's also going into the body as well. All right. So looking at a normal, it's quite easy to pick up an abnormal. So there's a few places where your odontoid peg can fracture. And we're going to cover that as well. I just want to just put this in a different. So you can have a fracture anywhere here. So you can fracture the odontoid process itself. So you can have anything over there. You can have a fracture just at the base, and you can have a fracture of the base and the body as what we see here. So those are the three that we have. Now, what's the danger of these fractures? Again, the danger depends on where the fracture is. So generally, if the fracture is higher up, it's more stable. It's regarded as a fracture that you can handle more conservatively. But as you start coming down towards the base and the body, what you're going to discover, of course, is that there's a greater chance that the ligaments that are holding everything in place have been disrupted. So that's where we have a problem. And those fractures tend to be much more unstable, and they tend to have a higher rate of complication, and they tend to have a higher degree of how can I put it, aggressive management. So you need to be more aggressive as the spinal or orthopedic surgeon to go in there and try and sort them out. Now, again, this is not a decision that's taken in the emergency department. If you're working in the emergency department, you're never going to go and stabilize an odontoid peg fracture. Never. All you're going to do is keep your patient in a hard collar, but you need to know the danger of this. Why I say that is because if you start seeing things on your patient, so for example, with a low fracture, let's say a C1 fracture, or even this low C2 fracture, if you start seeing a few things, let's start talking about it. So let me just put a little text box over there. So if you start seeing bradycardia, you know that you're in trouble. Of course, if you start seeing paralysis, that is, of course, a major issue. You know that something has, of course, happened with the spinal cord, although these patients already have a bad prognosis. But if you see a patient with bradycardia, especially if it's intermittent bradycardia, then you know that you've got a problem. You've got something that's just causing the what you call it, the fibers running down to cause this bradycardia. It's unstable, let's put it that way. All right. So you've got bradycardia, you've got paralysis, and you've got shock. These are some of the things that we may see. Now, this shock is neurogenic as well. So neurogenic shock, and especially at such a high level, is extremely worrying because it's extremely difficult to sort out. So these are the things, the danger signs that you would see. So if you were to see any of these danger signs, these are the types of things that you would look at your patient and say, okay, listen, I need to get this patient to a spinal unit or an orthopedic unit, or I need to get them to somebody who can stabilize this much better than I can. The best that you can do in the emergency department is to try and keep the patient's neck as still as possible. So you're going to keep them in head blocks. You're going to keep them in a hard collar. You're going to keep them in such a manner that there is nothing that's allowing that spine to move. You're trying to essentially, keep them, how can I put it, immobilized to the greatest extent that you can. Now, the reason why I mention this is because once you've caused damage to the spinal cord, it's very difficult to track back from that. Any of you have worked in an emergency setting from your student days till now, you know, once there's damage, there's damage. There's nothing that we can do. I mean, there's billions being spent on how we can overcome damage to the spinal cord. So, of course, this is not something that's to be taken lightly. So, my own personal view of it is that if there's a high suspicion of fracture, it's better to keep your patient in a hard collar, in a head block, in the head blocks, until such a time as you have either a CT scan or at least an open mouth X-ray. At least, you know, you can do a trauma series. You can at least, and the open mouths are quite easy to do while your patient is lying flat. Your C-spine is a bit more difficult because it does sometimes reflect, you know, you can have steps that are not really there. You can have a lot of things that happen because of the patient's positioning, but the open mouth is one that you can really see quite easily, even if your patient is immobilized. So these are the types of fractures that we get. So the odontoids. So type 1 is an oblique fracture of the upper part of the odontoid process. Type 2 fractures at the junction of the process and the body. And type 3 would be a fracture through the body and the axis. So going through that, what we can say is that we've got a combination of type 2, or I suppose you can call it generally a type 3, or it could be a combination of type 2 and type 3, which are regarded as quite dangerous. So here we can see what it looks like on CT scan. So here you can see the odontoid process or the odontoid peg, and there you can see the fractures that are running through. So I didn't draw this. This was on the picture already, just to give you an idea of what it looks like on CT scan. So this may be something that you're faced with depending on where you work. Just to give you an example, in the hospital in which I am, we have access to CT scans 24 hours a day, but we don't necessarily have access to a radiologist 24 hours a day. So very often the doctors, they have to interpret the CT scans on their own. So this is the type of thing that you would look for on the CT scan to see if there may be a fracture. And it's quite an important thing to know as well. So I hope you guys enjoyed that. I hope you guys learned something from that. This is just a little spinal joke just to finish off. And you know, if there's any questions that people have later on, I'm sure, you know, it's a Saturday night. Most people are out having fun or working. So, you know, it's not a problem that nobody pitched up. The important thing for me is that you guys watch this at some point and at least learn something. So it's a very short presentation, and I hope you guys enjoyed it. And if there's any questions, you're more than welcome to message me either on our A&E learning groups on WhatsApp or Telegram, via Twitter, even via the YouTube comments. I don't mind, and we can always try and answer questions and things like that. I'll reiterate it again. You know, this is for those who are entering emergency medicine or who are exposed now to the emergency department for the first time. We're not talking about advanced emergency medicine. We're just talking about introductory things that a lot of people find difficult when they enter into emergency departments. And unfortunately, open mouth C-spine X-rays are quite difficult for a lot of people, especially in trauma. My advice is that if you have a patient with a severe injury or suspected C-spine injury, an open mouth is one of your first line investigations. And until you have those investigations done, do not send your patient out without any sort of immobilization of their neck. Make sure that you get it done. And if you have access to a CT scan and a radiologist, of course, much better. And yeah, I hope you guys will find it much easier to actually read these x-rays from now on, because as you can see, it's so simple. You are literally just looking for two things: alignment and whether the peg is okay. Okay. All right. Thanks a lot. Keep well, and hopefully I'll see you guys in the next one. Bye.